Oh, I never heard you to speak about the hypertonic solution. This I'm very curious.
No, I would prefer to speak about starches because I'm not so convinced they are so bad.
Okay,
I went to London too, and I defended the starch solutions. I did, because I think it's so easy to criticize and throw away. But we need solutions for our patients, and we need colorweight solutions, definitely. And some people say albumin solutions are too costly. Okay, but then we need to find alternatives. All right, let's return to physiology. That's what I like. And just consider the distribution of water in our body. We have an average-sized adult patient is about 45 liters of water. So we know that with glucose in water, we will never resuscitate a patient. We need to add some salt to have some osmoles in the solution. Otherwise, everything will go into the cells. And if we add larger molecules, colloid molecules, it's clear that the solution will remain more into the intravascular space. It's another talk, but when we review the entire evidence, it's true in sepsis, in ARDS, in post-surgical patients, as well as in other types of patients. Now, speaking about hyperosmolar solutions, this time we increase the number of osmoles to have more osmoles than in our blood, and therefore to attract fluids from the intracellular space into the interstitium, and from there, hopefully, into the blood, especially if we add colloids to the hypertonic solution. And of course, hypertonic solutions have been used in the treatment of cerebral edema to reduce the size of the cells, basically. But I will not speak about hypertonic solutions in neurology. I will briefly review the effects of hyperosmolar solutions, as they will expand the plasma volume. They may have also effects on the heart. They may increase contractility, although it's not always so clear. They may decrease afterload. And they, of course, increase preload. They may, of course, stimulate the vasopressin secretion by increasing the osmolarity. That's a basic endocrine mechanism. But they seem to also improve the microcirculation. By the hyperosmolar effect, they can limit the edema in the periphery. The endothelial cells are less edematous. There is an improved rheology and reduced endothelial edema, as I said, and improved microcirculation. And these solutions may also have anti-inflammatory effect and antioxidant effect, and decrease gut permeability, and in some models, decrease the severity of lung injury. Now, what could be the effects of hypertonic solutions in healthy individuals? In this case, in healthy sheep. It's a very nice study, very well conducted. I will not present the details of it. I will only read the conclusion, which is that there are global hemodynamic effects associated with the blood volume expansion, but there is no particularly beneficial effect on the kidneys. Okay. In hypovolemia, there have been several studies in hypovolemic shock, traumatic shock, and this is probably the most recent one, which is clearly negative, no improvement in outcome whatsoever. And if you like meta-analysis, this is a meta-analysis of the few studies which have tested clinically the effects of hyperosmolar solution or hypertonic solutions in hypovolemic trauma patients. This is another meta-analysis negative. Okay. What could be the indication, actually, in hypovolemic patients? Well, maybe when carrying IV solutions is a problem. So you could consider that the Army may be interested, because if you have to go to the field, you could resuscitate with less fluid, exactly as with colloids, or with colloids plus hypertonic solutions, you could resuscitate with a smaller amount of fluids. Actually, the Army is no longer very interested, because they are more interested in plasma, and now the dried plasma that can be carried by the Army people. Moreover, hyperoncotic fluids may contribute to coagulopathy. So exactly as with HES solutions and perhaps gelatin solutions, you would be concerned about hemostasis. The same thing is true here. You would be concerned about the greater risks of bleeding. Okay, let's move to sepsis. We have been interested in this for many years, and our first study was before I used PowerPoint slides, and actually I couldn't even find a reprint because it was in the last century. So I just copied the abstract here. And we found that in a model of endotoxic shock, the administration of hypertonic fluids could indeed have a plasma volume, a blood volume effect, and could facilitate the early resuscitation. But we said for how long this can last, that's a good question. Should be a transient phenomenon. Now, to be honest, here this group of Asiatic investigators published several years later, but it's still about 10 years ago, a very nice study performed in rats where they showed that hypertonic saline could protect the organs in sepsis, and perhaps it had anti-inflammatory effects. We do not have much more in animal studies, but you would like to see some clinical data. And there are only a few old studies which did not really show a benefit with hypertonic solutions in septic patients. And there are two more recent ones from China, and they are also negative, no real benefit. So this is a very interesting French study from Dr. Asfar and collaborators, who did a study addressing two questions: hypertonic saline on the one hand, and hyperoxia on the other hand. We will not speak much about hyperoxia this afternoon, but if we focus on the data with hypertonic saline, it was not very good either. There was clearly no difference in mortality, but if anything, the numbers are relatively small, but if anything, the trend was going in the wrong direction. So the study was stopped before the end for a greater signal of harm with hyperoxia, and we know that this is now well supported by a number of data. Okay. I was invited to write the accompanying editorial because I reviewed the paper. I liked it very much. And indeed, I considered, and I consider, that there is actually little place for hypertonic solutions in septic patients. Despite the hemodynamic effect, but we could simply give a colloid or give more crystalloids to obtain the significant effect on blood volume. Now, there is a risk, though, if we speak about hypertonic saline. Hyperchloremia is not good for you. Any metabolic abnormality is not good for you, but hyperchloremia certainly is not good. Some people say that we discovered recently that hyperchloremia may be bad for the kidneys. Recently, it was in 1983, that hyperchloremia may alter the hemodynamics of the kidneys. An excellent paper in the Journal of Clinical Investigation. You can look at other excellent papers from the last century showing how hyperchloremia may affect renal hemodynamics. This is another study from the last century showing exactly the same thing. So we must be concerned about hyperchloremia, not about saline solutions, no, about hyperchloremia if we give too much chloride to our patients. So we need to monitor the chloride levels. Or we could perhaps consider hypertonic lactate. Lactate, as we know, is an index of altered tissue perfusion. That's how we use it. But by itself, it's not toxic at all. It could be used by cells. Our heart, our brain could consume lactate and other cells as well. The group in Lille has produced some interesting data on hypertonic lactate in small animals, but it's an endotoxic shock model. Today, we have our hesitations about the validity of this model. But nevertheless, it shows that the fluid balance is less positive with hypertonic lactate. They just published another paper in the Annals of Intensive Care, where they showed perhaps some renal protection with hypertonic lactate. I must say that we have not had a similar experience. In our large model of peritonitis in sheep, a model where we keep the animal alive for more than 24 hours, so it's really a clinically relevant model. We can monitor these sheep quite extensively. We compared hypertonic lactate to hypertonic saline to normal saline solutions, and Ringer's lactate. And what we found was that, of course, lactate levels increased more with hypertonic lactate. That's not a surprise. But the bicarbonate increased more as well. As we know, lactate is a base. It's transformed into bicarbonate. But when we looked at the microcirculation, it was altered rather than improved with hypertonic lactate. And when we looked at regional blood flow, regional perfusion, and regional microcirculation in the brain of these sheep, it was rather altered with hypertonic lactate. And if we look at the kidneys, the same thing. Renal blood flow was rather altered. The microcirculation in the kidneys was rather altered. And if we look at the duration of survival of these animals with peritonitis, it was shorter in the hypertonic lactate-treated animals than in the others. You may say that the differences are not so big. Well, it's still a few hours in a model where the animals typically live for 24 hours. So we were actually disappointed, as there was also an earlier onset of impaired tissue perfusion in addition to the shorter survival time. I will finish up with a systematic review of randomized controlled trials on hypertonic saline in human sepsis. I received a letter of acceptation by anesthesia and analgesia just 20 minutes ago. So I changed the slide to indicate that it is accepted for publication. And when we review this literature, it's not big. It's only 8 randomized controlled trials and a total of 381 patients treated with hypertonic solutions. But as expected, we need to give less fluids to obtain the resuscitation endpoints. Of course, there is a transient increase in sodium and chloride concentrations with hypertonic saline, and the beneficial effects on there are beneficial effects on some hemodynamic variables and on some immunocharacteristics of these patients. These are the forest plot. You can see that indeed less fluids is required. That's not surprising. That's physiology. And in terms of mortality, maybe it's a little better with hydroxyethyl starch. No, I shouldn't say that. No. Hydroxyethyl starch. associated with hypertonic solutions. Perhaps it's okay. And my conclusion is that there is actually very little place for hypertonic solutions in hypovolemic states and in septic states. So largely because it's not physiologic, after all, to increase the osmolarity. So if you like, if you are in a mood to eliminate everything, you could eliminate the hypertonic fluids as well. Likewise, the Ringer's lactate solution, because they are somewhat hypotonic, so you should not use it unless the patient is dehydrated. We call these solutions Hartmann solutions because Hartmann was a pediatrician treating children with gastroenteritis. We spoke about plasmalite and acetate, gluconate. We have questions about this. We will hear that albumin is expensive, we shouldn't get it. So, okay, we can throw away everything, but if you like, you can also have your doubts about hypertonic solutions. I don't know if JLV is still in the room because I fully agree with him that wine is the best solution, but we should not use hypertonic wine. Thank you very much indeed.
Please, question from the floor. Great. Be careful, huh? Was jogging, okay. Go ahead, relaxed. Okay.
A very simple question. In your presentation, you mentioned about the hypertonic saline and the hypertonic lactate. What's your opinion on hypertonic albumin, 20% and 25% albumin?
I didn't speak about albumin because my good friend Luciano, I think, is the next speaker. No, I mean, there is someone speaking about albumin after me. But I could speak a lot about hypertonic albumin, or rather concentrated albumin, the 20% solution that we would give to patients who are already edematous or with a low albumin level. I always smile when people say, in the initial resuscitation of patients, I always use crystalloids first. I don't. No, not at all. If I have a cirrhotic patient coming in with septic shock, I treat these patients correctly. I would not give saline or plasmalite. No. If it's a cirrhotic patient with anasaga, I give 20% albumin solutions, of course. Of course, why would you give more salt? They're already full of salt. So give only what the Americans call SPA, salt-poor albumin. So that's the concentrated albumin solution is a solution that will bring albumin with minimal salt. It will be a little bit, but it will be salt-poor. And so you could, in patients who make urine, you could combine it with furosemide to eliminate edema, like in patients with ARDS who are hemodynamically stable. So you would use diluted albumin, 4% or 5% albumin solution, depending on what you have in your country. That's for a fluid resuscitation therapy in patients who do not have massive edema. So in a way, it's as if you were using the concentrated albumin solution and adding some saline, and you mix it together, and you make a 4 or 5% albumin solution. So there is no miraculous difference between the two. It's just that the 4 or 5% is more diluted. You will bring some water and sodium in addition to the albumin, and with the 20% albumin, you will give only albumin.
There are other questions? Well, just one question, Jan-Lui. Is when we speak a movement of water from one compartment to another one, we speak about difference in osmolarity, okay, or oncoticity, which is the osmolarity of the proteins, which is very low, 2-3 milliosmol per liter. Now, if you take a piece of paper and you compute how much is the water transfer from one compartment A to the compartment B to re-equilibrate the system, you found that if you use half a liter of the amount of water is very, very low. So when we speak about, yes, when we speak about, it's very simple, Jan-Louis, we fight a lot of that. But if I have a bottle of 5 liters and 15 of liters, and I have the osmolarity 305 and 300, to equilibrate the two is enough half a liter of water. And this is mathematics, physics, biology. Point. There is no question about that. Because it's as to
in
say
terms of osmolarity, but you are speaking with the wrong, you are starting from the wrong concept. You need to go back to Starling, not the Starling relationship of the heart, but the Starling equation for the periphery, where the amount of fluids leaving the vasculature is determined by the first factor, which is related to hydrostatic pressures, and the second factor, which is the difference in colloid osmotic pressures. I was trained with Dr. Weil, who invented the oncometer, so I've used it a lot. We were measuring the colloid osmotic pressure in our patients in Los Angeles, and the normal colloid osmotic pressure is around 25 millimeters of mercury. And it's not uncommon at all to find patients having a colloid osmotic pressure of about 15, if not below. Of course, if they have an albumin level
Jan-Louis,
of
why don't you tell
1.5
the
instead
people,
of 3, of course their colloid osmotic
Jan-Louis,
pressure will decrease
you
by
have
1/2.
25, 20 millimeters of mercury due to the protein. Why don't you tell them how many millimeters of mercury are due to the other component? 5,000.
No. The colloid osmotic pressure is influenced or determined for about 80% by albumin. Globulin, very little. Fibrinogen, very little. If your patient is on heparin, a little bit. So it's primarily albumin. Let's go back to Gaetan. Let's take a textbook of physiology.
Okay,
Let's open it.
Okay, cool.
At the page, colloid osmotic pressure,
Okay,
Luciano.
buy a recent book of physiology, not of 2 century, past 2 century. But just to the curiosity, just to rise in some young people, the curiosity to take the quantitative approach to the thing. Movement of the water, try to take a piece of pencil, look at the Starling, look at the hydrostatic pressure.
And measure the colloid osmotic pressure,
That's all right. We measured it when I was 20 years old. It's a long story. Just don't believe always to what you heard. At least always doubt, including what I say.
Yeah, I doubt about what you say. Yeah.
Okay, gentlemen, thank you very